So as we go through these lectures, last week's, next week's, and the week after, you'll see that there's quite a lot of links. And you might think, well, she said that last week and she's repeating it this week. And that's because in most cases, people have more than one of the conditions that we're discussing. So someone who is living with obesity may also have type 2 diabetes or high blood pressure or hypercholesterolemia. So when you're actually working with a patient, you need to understand the different aspects, because they might be one of those people who just has one condition, but the reality is that majority are going to have more than one. So we need to be looking at a very holistic perspective. So if we look here, this diagram kind of gives you an idea. We've got obesity, which we talked about last week. Diabetes, we're going to talk about next week. But if this gives you an idea, the obesity, more abdominal fat, more insulin resistance, and that is more likely to end up with diabetes. High blood sugars, damaged artery walls, and we're more likely to have high blood pressure coming through and high cholesterol, and all of this linking to cardiovascular disease risk. So have a look through this and have a think about it and how it might all be linking. Because the reality is it most likely is. So let's just focus a little bit on lipids, because we tend to associate those most with cardiovascular disease. And again, I'm sure a lot of this will be revision for many of you. So lipoproteins carrying around the blood and traveling around, and they're made up of triglycerides, which comes from adipose tissues, fat tissue. They will have cholesterol and they'll have proteins. So we've got the lipids and the proteins making the lipoproteins. And they have historically always been classified by the density of them. So they're varying size, varying density. And there's just a little look at the kind of structure of a lipoprotein. So what does that mean for us? So we have low density lipoproteins. They're carrying cholesterol around the body. They are more likely to stick to the blood vessel walls, and they're the ones that are most likely to cause the narrowing or blockage of a blood vessel or atherosclerosis. And how that links to a heart attack, there's a link there for a YouTube video which will explain it much better than I ever could. But these are the ones that we tend to think of as bad lipoproteins or bad cholesterol. But the high density lipoproteins are the ones that kind of mop up the cholesterol and take it back to the liver where it's broken down in excretion. So the high density lipoproteins produced in the liver, they're anti-inflammatory. They are much less likely to stick, causing atherosclerosis, and they're much more likely to be able to prevent the monocyte aggregation, less plaque buildup. And they also carry an enzyme that prevents the low density lipoproteins becoming inflammatory. So the ratio between low and high density lipoproteins, we've known for a very long time, is really important. And it's not just therefore about total cholesterol, it's about the balance between these and the lifestyle factors that are going to influence them. And that includes saturated fat intake, smoking, high alcohol consumption, and physical inactivity. Let's just kind of remind you really of some of the stuff that's going on at a little bit more of a cellular level. Endothelial progenitor cells, got to say that carefully, they play a role in regenerating the endothelial or the blood vessel lining. Multiple different types of cells, but really important role in repairing the damage and protection of the blood vessels. So the most common fats that we have are triglycerides, and these, from a dietary perspective, are closely related with refined carbohydrates and sugars and alcohol. So if someone has a very high triglyceride level, but their cholesterol, total cholesterol, LDL cholesterols are lower, then I would be very much looking at, sugar intake and alcohol consumption, because those are most likely to be causing that high triglyceride level. So we've got the dietary sources, we've got that potential damage to blood vessels, the HDL taking the cholesterol back to the liver. They're just going to give you a picture of how those things link together. So we need to think a little bit about measuring blood lipids. And what we have understood about raised cholesterol levels for quite a long time. And this analogy works for some people, so you'll go through it and see if it helps you to understand. So we're thinking about arteries as roads, lipoproteins which carry cholesterol as cars, and the cholesterol as passengers. So how does that relate to blood lipid levels? So total cholesterol and low density lipoprotein cholesterol measure the number of passengers in the cars. However, there's a bit of more recently thinking, well, actually, it's the number of the cars, the number of lipoproteins, which increase cardiovascular disease risk. And then we've got the difference between the HDL and non-HDL cholesterol. So this is really important, and this is what we now think makes a lot more sense. So we are looking at total cholesterol and anything that isn't HDL, so the non-HDL. So that's what we would be looking for now, rather than just the total number of passengers in the car, which was the amount of cholesterol. So just to give you here an example, so if someone's tested with their bloods and they found their total cholesterol is 6, their HDL is 0.8, therefore the total of the rest of it, which is seen as the bad cholesterol levels, is 5.2. So we are looking, the targets are to get non-HDL cholesterol below 4. Or if someone's already got cardiovascular disease, below 3.4. And that's related to that risk of developing cardiovascular disease within the next 10 years. And we just now believe that the non-HDL is the best measure because it tells you a lot about the balance between the two. That just gives you that example of how you'd work out the non-HDL. So what levels are we aiming for with lipids these days? So total serum cholesterol below 5 millimoles per litre. The non-HDL below 4. LDL itself below 3. And the HDL, there's a bit of genetic difference, but above 1 for a man, above 1.2 for a woman. And then we've got the total cholesterol, versus HDL, the ratio. So if it's above 6, that is high risk, so we want it below 6. And triglycerides should be below 2.3. So HDL doesn't need to be very high. It actually shouldn't be above 1.4, because that could actually be being influenced by other aspects like a poor diet or excessive exercise, excessive alcohol, and some medications. So we really are looking between 1 and 1.4. And physical activity is one way to try and help get up that HDL to a healthy level. So what does physical activity do to our lipid levels? And you need to be able to discuss physical activity with patients. And so being aware of what the recommendations are. So we know that good levels of physical activity will reduce the LDL and increase HDL. So it's going to be really important from that perspective of lipid management. And the recommendations, avoid sedentary behavior, again, looking at the moderate physical activity, for 2.5 hours, 150 minutes to 5 hours. If it's vigorous, you can use less time. So it's 1 to 2.5 hours per week, and we're trying to get these 10-minute blocks of physical activity, 30 minutes moderate to vigorous physical activity in patients who've had myocardial infarction or coronary artery bypass grafts, have angina, or stable chronic heart failure. So what I need you to realize is that for those who've got some level of heart disease, the recommendation is going to be quite different. If we're on prevention, we're looking at the standard recommendations. If you look back to the weight management ones, those were much higher. So you've got to think, am I just dealing with weight management, or am I dealing with weight management and cardiovascular disease? And does this person have an element of heart failure, in which case this is going to have to change? So be aware of the way that we may have to change things slightly, dependent on the patient in front of us and that combination of health problems that they may have.